All right. So tonight's going to go pretty quick because we're talking about healthcare, and it's not stagnant. Well, stagnant. It's not. It's very dynamic. Let's just put it that way. I've been, scrubbing the internet looking for some impartial comments. I mean, I have my own opinions, but you don't want to hear those. But anyway, so I'm looking for somebody, middle of the road, pros and cons. It's not out there. It's there's the what's in 1984 the Ministry of Truth, the government site that's just saying it's the greatest thing ever. Okay, I'm not going there, but we know that there's maybe some things. Yeah. Okay, there we go. That's what I do. And then there's some other stuff that actually come to fruition. But the deal is like I said before, that healthcare is, again, I don't think this is being overly pessimistic, but the system wasn't maybe designed to work in its current form because nobody really wants this sort of in between. And it's going to be dependent upon the elections. Both candidates or both parties, whatever, have radically different views. And obviously, one of those folks is going to win. And so depending on who it is, it's going to go one way or another. But the basic gist of it is what people on the left side want is a single payer, which means that payer being the government, so it's a full up, there is no private sector health insurance. And on the other side, on the right, they want private plans. Anyway, the current system, or the old system, wasn't a good one. It maybe needed reform. But anyway, what we've got right now, this hybrid kind of system, it's not serving the needs of anybody. It's really unsustainable financially. So we won't talk too awful much about it. We will show, like, for example, some of the things that were supposed to work. Once again, the slides stick. Come on. So, and there is some long-term health care that we'll talk about and some disability insurance. So that's all good stuff. We could talk about what's kind of unique in the U.S., highest per capita medical expenditures of any industrialized country in the world. But again, how do you want to cut this back? You want it to be your parents, or is that where the savings is going to come from? So anyway, there's some inefficiencies out there, but yeah, there is sort of a tradition within the United States of doing everything that's possible. And if people choose to use their life savings to do that, or pay for extraordinary insurance to try and do that. Anyway, also some of the costs, and I'm not trying to defend, but there's a lot of fraud in the system, one, and then there's just other things going on. But twice as much spent on healthcare as the average for the 24 industrialized countries in Europe and North America. But again, it's kind of comparing apples to oranges. There's some unique things that happen in the United States that are different. I've lived in Europe for probably 14 years altogether, and systems are completely different. And the demographics and the other things. There's a lot of times where statistics or comparisons are made, but they're not like type populations. 6% of GDP in 1995, but continue to rise, and high administrative costs. 11% of healthcare dollar versus 1% in Canada. But part of that also, basically 20% of the U.S. economy was healthcare, and so when you take that out of the equation and make that government program, of course, the private program, it will have an effect. And anyway, different things. So this is what it was supposed to do: reduce long-term healthcare costs, protect families from bankruptcy, guaranteed choice of doctors, invest in prevention and wellness, improve patient safety, and the rest. But there's been some changes along the way. In fact, some of the new plans, the deductibles are up to like $6,500. So when we talk about why you need an emergency fund, a deductible for an insurance plan, if you're carrying insurance that costs $6,500, yeah, you need an emergency fund to cover that. There's different healthcare systems, and where the Affordable Care Act, or Obamacare as it's called, is really in the middle. if people are very, very poor, you have Medicaid, right? Once you get older, 65 and up and stuff, you get into Medicare. And then in between, you have these, in between that lower income level and the older folks, you have the Affordable Care Act. So a lot of times, part of the problems that the system had was you had a whole bunch of people who signed up for the Affordable Care Act, but due to their income limits or their lack of income thereof, because of their situations, they actually ended up on the Medicare rolls because they're Medicaid rules. I'm sorry, because it's they qualify for welfare. So again, expensive technologies. Well, if it's my child, yeah, I want the best that's out there. Duplication of tests and technologies. A lot of that has to do with some of the litigious nature of our society. So that is different than Europe. I'll tell you, not everything is great in Europe, but I do like the fact that, like Germany, for example, if you wish to stick your hand into the blades of a lawnmower, you can't basically say, well, there wasn't a warning sticker that told me I was, they're a little bit more on the big boy approach, and the lawyers are not as prevalent. There's not as much litigation. So but anyway, duplication of tests and technologies. Doctors do want to be basically bulletproof when they go to court over any sort of malpractice, that they took every test and duplicate tests and the rest of it. Variety and frequencies of treatments. Yep, people are living older. Yes, and regulations that result in cost shifting rather than cost reduction. So a lot of that too is some of our, and I'm not a proponent saying, oh, what we have is a great system. It was pretty bad. It's not that much different, but for example, I had my foot worked on, and I was under a private healthcare plan in addition to TRICARE, the military, and between the two of them, yeah, it was well in excess of 100 letters they generated trying to talk about how they're going to pay for my foot, and it was just silly. It was, I could have gone to Costa Rica and got the job done, and probably for the same price of all those letters going back and forth that costed. So anyway, it is different, but you will find people, again, getting back to the international model. I've spent a lot of time in the Baltics, and a lot of the tourism there is what they call medical tourism. It's people who are under what the authors of the book claim are these great medical plans, where these guys go in to get their denture, or not dentures, but dentistry and other kinds of surgery done. They go to the Baltics and they pay out of pocket because they don't want to wait in a queue and the rest of that, a line. So it's a difficult situation. It's always going to be. It's healthcare, and you're talking about people that are sick and the rest of it. So it makes it very, very bad. Other things. Increasing number of accidents that require emergency service. I'm not quite that pessimistic. I think, crime is what it is. In fact, murder rates are actually down. If you live in Chicago and you're worried about gunshot wounds, yeah, maybe. But for most of us, I don't think there's been a definite change in that. Limited competition, restrictive work rules, and again, that is, obviously if you go to single payer, then there's no competition. Labor intensiveness, rapid surging growth of healthcare professionals. Tough call. The doctors will say they're making no money at all. They're saying they're being burdened with all these malpractice insurance claims. They've got this. They didn't even start earning income until they're through about 8-10 years of college. So it's a tough gig. Innovative treatments for AIDS and cancer. Again, yeah, that stuff's expensive. But that's the other thing, especially when you're comparing the U.S. to Canada. I mean, there's not a whole lot of new drugs that come out of Canada. And if you're developing new drugs, for example, most of them don't, make it through trials. And so when you do have a successful one, they're going to charge a lot for it because it's not only paying for that drug, it's paying for all those other drugs. So what do you want to do? Anyway, you're already seeing a tapering of medical research because it's not worth it. Built-in inflation in healthcare delivery system, certainly. And then malpractice insurance, which you've hit on a couple times, and aging baby boomers. You go to other places. In fact, it was very sad. His wife ended up dying, but she had fairly advanced cancer, a friend of mine, and he was a Dutch guy, and he came back, and they gave her magnets. I mean, that was the extent of the care. They're like, we're not treating this. This is a very low probability of surviving here, and we've heard good things about these magnets, and anyway, so again, it doesn't take too long to be in this situation with comparing the healthcare systems across the way. You really want to do a perfect comparison, and anyway, some sort of solution is going to come out of it. But my intent is not to talk all night about things that are going to change literally within the year. So what's being done about it? Yeah, fees and charges, incentives, preventive care, exactly. Out of hospital, you see that more and more. And again, these are kind of market-driven things. I mean, look at the price for having your eyes worked on, which are normally not covered by insurance. I mean, it's quite reasonable for laser surgery, and the prices that people can do things in, say, Costa Rica, or Costa Rica is a pretty popular location for people to get medical work done here, but in Europe, it's different places. So, but anyway, that's usually done out of the hospital. Balancing health needs, healthcare resources, certainly, and prepaid group practices. Those are kind of being eliminated by the other parts of the healthcare plan, because there's for example, folks like you're in good shape. You're young. Your chances of having any types of problems are minuscule. So you would get typically what they call catastrophic healthcare, with maybe a high deductible, but it'd be very, very affordable. And you'd be covered if you got something, whatever, something drastic. But those options have now been eliminated because all the healthcare plans have to meet minimum standards. And so it's changed the complexion of it as well. And then also, just like we talked about with car insurance and other things, there's sort of a balancing of the big pool of insurees. So the younger folks that are you and healthy, you have to basically pay more into the system, because for the older folks it'd be unaffordable for them to pay what they're really going to take out of the plan. But the problem with that is that the younger folks aren't going to sign up if the rates are that high. Right now there's penalties, tax penalties, if you don't sign up, but they're pretty small. But they ramp up here over the next couple of years. Yeah, but that's this year, and then the next year, and then and by the time it's going to be, it's a penalty now. It's going to be anyway. It's meant to ramp in over time. People take better care of themselves, certainly. That would always help. Flexible spending account, if eligible, but again, this is kind of going by the wayside, because now you have these mandatory plans. So, high deductible plan, not possible anymore. Yes?
What chapter? Sorry.
Oh, this is a chapter, it's week 9. We're talking about healthcare.
Okay.
Yeah.
Sorry, I was late.
No, it's not a problem. Yeah, but the high deductible plans, that used to be an option, and it used to be an affordable option, but that's not the way that the plan is worked out to make it affordable for anybody. The younger folks, the healthier folks, have to pay more than they'll ever take out of the plan. Less expensive generic drugs, those are generally mandated now. Mail order pharmacy, we've had that. Low cost coverage for uninsured children, that goes into the Medicaid plan. Prescription drug assistance, again, this is under the Affordable Care Act. Non-urgent procedures, errors. Health plans are kind of going away. I mean, it's still, there's a thing. How many people work more than 30 hours a week? And how many work right at 30 or just a little bit below? Yeah. Because, I mean, so you're seeing some of the effects, because above 30 hours they have to provide health insurance. Below 30, so it ends up a lot of people, not a lot, but a number of people with 2 jobs, and that way the employer can skip out on that. Not nice, but that's the game. So yeah, you're going to do all these things just on your own. You know, live carefully and live healthy. So now, disability insurance. This is kind of important stuff because this affects you. Well, we're going to talk more about people with no health insurance. The number hasn't dropped that significantly, even with the mandatory stuff. And this 45 million number is kind of specious. They counted all the whatever the term of the day would be, but undocumented folks, about 12 million people who, you know, would not maybe get health insurance. Student population. So this is more health insurance. Yeah, sometimes there were some people, and there were some really, you know, I'm not saying that the private sector had done a great job in this. There were people who had hit a lifetime cap and would perhaps lose their insurance. So that has changed. But the part about the economic security is true. But now there's a lot of folks who just can't afford any insurance. They do have the Affordable Care Act insurance available, but just because it's available doesn't mean it's affordable. So, is anybody covered under affordable? Are you? No.
I have a couple of my clients that are.
Yeah. And what do they think? Are they positive about it?
One of them really likes the insurance because there's only 2 providers in the state of Alaska. One's Blue Cross Blue Shield. And there's 3 plans you can choose from.
Yeah.
And you either get a reduced cost depending on your income or a tax credit at the end of the year.
Yeah.
But she has a young family and stuff, and so it's really been great for her.
Yeah.
But a lot of the stuff with the Affordable Care Act, kids coverage have changed, age limits for kids have changed, and stuff like that. But I have another client that's expensive, but it's still cheaper to find your own policy.
Yeah. Well, that's the traditional thing was most people got their insurance through their workplace. But now that's changed a bit. And also some of the you know, things that you may or may not need in terms of if you're selecting your private insurance plan. You may say, well, I might not need whatever service. Some of those services are mandatory parts of it.
Yeah,
So.
well, like your group coverage plan, you're paying for everybody to be covered getting pregnant.
Yeah.
But not everybody in the company is going to get pregnant.
I'm pretty certain. I don't need that coverage, but I do pay for it.
You do.
I'm not considering gender change anytime soon, but you know what I mean. So it's like, anyway, it can get weird. But disability income is you know, serious stuff. I keep up, and we're going to get to that, but we're talking more about group insurance. So, yeah, group plans like we're talking about, they do cover, you know, 90% of all health insurance. So these are usually, you know, employer provided. An employer does subsidize typically most of that cost. There's some other ones. 1996. Again, this has been superseded largely by Obamacare, but you know, we had COBRA and some other elements to it, and it basically it kind of recognized the fact that people are much more mobile in the workforce. That it's very almost non-traditional now to work at the same place for your entire career, and so they made some modifications to ensure the portability of the health care. Yep. Generally, you can get supplements to your group policy, and it's not unusual to have competing policies, and that's where a lot of the problems come up when you have 2 different coverages. One's got to be the primary, and one's got to be the secondary, and so then there's this haggling that goes back and forth. And then also you have to have providers that are going to pay for it. The reimbursement a lot of times is such that the doctors aren't interested in taking certain clients because they're, you know, the doctors feel that they don't make enough to cover their costs, so they won't accept the patients. Anyway, I've luckily been very healthy and not had to deal with too much of this stuff. So, you know, I can only tell you what I've read, what I've looked at, and again, it's, you know, it's like we talked about in taxes, about being able to deduct your medical expenses, where they have to hit a threshold it's pretty scary for most people. Yeah. What was that threshold again?
It's 10% of your adjusted gross income.
Yeah.
Above that.
Yeah, 10% of the AGI. So if you're making $100,000, you're paying over $10,000 in unreimbursed medical expenses. That's not good. So you don't want to be there. Yeah, they're telling you what a plan should cover. Guess what? Those minimums are now specified. So there is a standardization in the plan, which is a good thing. Bad thing is, you know, my pregnancy coverage is going unused. Types of medical coverage, hospital expense. Some of these are again OBE due to the Obamacare system. There was also these physician expense insurance where they used to have individuals. Still may be available, but they're really being phased out. This gets into, you know, catastrophic type things that again are OBE, overcome by events, in terms of what's available. Because now there is a mandated, all plans must cover these things. There is no lifetime limits, and so some of the stuff is good. Children will be covered to age 26 on their parents' policies. So all those things that were features of a good plan. What's that?
I said, thank God.
Yeah, exactly. Yeah. Hospital indemnity. Okay, now dental and vision care are still in there. Dental and vision care are outside of those programs, but they're generally available through your employer, and they're not that much money. Dental expenses seriously can get out of control quite quickly, so that's a good one to have. And the vision care is usually so reasonable that it's kind of a no-brainer.
Children under 18, employer coverage is now required to cover them for both vision and dental, so,
yeah.
Which it used to not be.
Yeah, so there's some good aspects to it, but you'll find those. And again, this gets into that cafeteria plan, like we were talking about on the test, where some things are optional, and you know what I mean? Yeah. When are you going to do that? You're going to do it?
I'm going to do it.
Yeah, because
I haven't taken it yet.
Yeah, we'll exclude you here in a few minutes.
I'm not going to do it.
No, you'll do it. You'll do it. So long-term care insurance. This is something that you seriously may want to think about, because this is you get in a system where you end up in a nursing home type situation. Number one, I'm not sure I'd wish that on myself. I would rather invest that money in a Ducati or an airplane or something like that to go, okay, I came into this world wearing diapers and not leaving it. Check it out, But anyway, for the rest of you, there are some people who spend a great deal of time in a nursing home, and that can get quite expensive. So, exactly. And so if you have a home, and I actually ended up with a home in this situation. We bought it from my ex-wife's grandmother, because she didn't qualify for the insurance because she had assets. So she needed to get rid of the assets. So sold the home and took that, whatever it was, 30 or 60 grand. It wasn't much of a home. And that went to pay the insurance, and then she was basically destitute, and the government took over. Bad things happen, it's end of life type stuff. So if you have long-term insurance, and especially in that nursing home type situation, you're better off being prepared for it. Can be very expensive, but guess what? It's more reasonable when you're younger. There's a chance, and again, this isn't positive thinking, but this is insurance company thinking. This guy's paying for insurance that he's not going to use till he's whenever, in his 60s. He may not make it. He may just die of a heart attack. he may not have this long lingering death. But if you get to the point where you've established that you're going to be in this long lingering process, and then you go to get the insurance, from an insurance perspective, you're a bad risk, and you're going to be a very expensive risk. And this is private insurance. This part is not, subsidized by the government. So 72,000 is what they're saying, which is, go figure. Alaska is never below the national average on anything. So 9,500 a month is probably, and these numbers are probably kind of dated based upon their comments on Affordable Care Act. So premiums $1,000 to $16,000 per year. Again, with one of the employers I have, they actually have an option for long-term subsidized, that type of insurance, and so do it before you're knocking on the door and you're all right. So they're talking again back to standard health care that was, I didn't mean to gloss through every bit of that, but again, a lot of this is mandated now, in terms of the pain, in terms of the fix per day, and you just have to find a hospital that's willing to take the plan that you have available. Co-payment, that still exists right now, where you go to see the doctor and you have to put down, typically, at least TRICARE I know is usually $12. I don't really know the point of it. It's just sort of, I guess, some incentive to not go to the doctor every day, but $12 isn't much of a disincentive. But yep. Exclusions, limitations, coordination of benefits, guaranteed renewable. Again, these things are being mandated rather than the flexibility. So there's still specifics within the plan. You go to the marketplace, but the marketplace, the parameters of the plan are largely predetermined. So you don't, you can't go, I want the high deductible and I don't care about this. No, it's more of a standard plan. So private sources, again, they still exist out there, but there's not as much flexibility for anybody. We talked about a couple, Blue Cross, Blue Shield, still out there, but if it were to go to single payer, I think those folks would go away as well. There were some issues, some of it had to do with marketing type things. There were some archaic laws where they weren't able to work across state lines selling insurance, and there's some reforms that could have been put in place, but anyway, they did not occur, so that's how we ended up where we were. HMOs, again, kind of an artifact. I'm not going to spend any time on them because we're stepping away from that. But yeah, you may have heard of HMOs in the past and prepaid health plans. Now we're going to exchange type things. And PPOs were part of HMOs, where you found basically somebody who would take the type of insurance you had to offer. So, I don't think in Alaska it's as much of a problem, but there's certain places in, say, California, for example, where there's doctors that aren't participating or retiring or whatever. It's causing some issues, some shortages. Employers self-funded. Not too many of those, as the traditional big pension plans and the rest of it. Health savings accounts, flex spending accounts. A lot of times there's income limits on what you can do with those. UA, the benefits package is there. I didn't qualify for any of them due to external income. So it's all going to be means tested is what I'm trying to say. Now we talked about, Obamacare, Affordable Care Act type people being in the middle. The upper end, people for those 65 and older and Medicare is that program. They had different parts to it. So Part A was the hospital, B was the medical insurance, C was the advantage, kind of a stopgap to fix some of the shortcomings. And then D was a little controversial, but it's the prescription drug benefit. D was obviously the newest addition to that program. Medigap and Medicaid. So Medicaid is more of the welfare type program. So people who are, without, the means, get some type of insurance for free. So state administered with federal guidelines. So, and there's always the, not that it'd be pretty, but emergency rooms cannot refuse to treat people because of lack of funds. So but again, that burden is transferred to the hospital, and then the hospital makes it up by charging the other people more. Medicare fraud, sure, it exists. If you were able to find Medicare fraud, you can actually make a bit of money. It's funny, in a grim sort of way, that the statistics, like for Guinness World Book of Records, that when they try and find the oldest people in the world, they often find that it's fraudulent. Especially in Japan, for example, where they literally had to go through the 5 oldest people till they finally found a person who was actually alive, because there's so much fraud that the person was drawing a pension, and so although this person died, they put him in the yard, did whatever with him, but they certainly didn't report him as dead, and so the money keeps rolling in. And in the United States, it's not as bad, but there are more people than you would think, well under their hundreds that are, not here. So fraud is a big issue. Affordable Care Act of 2010. Where they got a lot of this money was it came out of the Medicare plan, so it has made things a little tougher on seniors. But anyway, some of the provisions, dropping coverage when people are sick, require health plans to allow people age 26 to remain, co-payments for preventive services. Again, I don't think the co-payments were really a hurdle there, but if you're going in there for preventive type things, there shouldn't be anything at all. Lifetime caps went away, annual limits, increasing the money for health care. But anyway, you can see all these things. There's a bill to be paid at some point, and that's what's happened now. It's being reflected in the premiums and the deductibles. So that's what's making the plan a little bit unsustainable. But again, a couple websites there you can always look on there. HHS, National Institute of Health is NIH.
What was the last one? It said 635.
Yeah, don't worry too much about taking notes on this part, because this is
that's crazy though.
Yeah, well,
I mean, we need it, but
yeah, the numbers on all this stuff were, and there's some things like we talk about where the penalties, they were meant to phase in to make the numbers right. It all started out as a big political thing where it was supposed to cost $1 trillion more, which equated to the cost of the Iraq and Afghanistan wars, and so there was some sort of equivocation there that if we can spend that much money on wars, we can spend that much money on health care. Well, anyway, those numbers are all changed now. We could have done a few wars with what we had. But disability insurance. So back into more focused mode, because again, I've just been not rambling here, but the information is it's jello in terms of healthcare right now. We're going to have to wait and see what happens. And again, a year from now, there will be a new president and there will be a new direction. So what that direction will be, do not know. Your guess is as good as mine. Who's even going to get elected? But disability insurance is not going to go away. Disability insurance is the type of insurance that means that you're no longer able to work. So, and it depends what your line of work is. If you're working in an office, maybe you can get by and still do your job if you're, confined to a wheelchair. But if you're a roofer or something like that, and you fall off a roof, your work life is done. So there's been a lot of fraud in this as well. There's lawyers, the guy with the cowboy hat, Bender and Bender. You ever see these guys on TV? Okay, so what they do is they get people, they go to the states, well, the states go to them, whatever, it's a mutual arrangement, but the states will pay those guys $1,500 for every person that they can take off welfare and put on disability. Because disability is a Social Security disability. Social Security disability is a federal program, and welfare is a state program. So what we're talking about here is mainly private disability insurance, but the other kind of disability insurance, the Social Security, it's been kind of devastated by the number of people that are, on disability for, obesity or different things that clearly, prevent them from being able to work, but again, people have control. But in this case, what we're talking about here, though, is more like the guy falling off the roof, where I'm talking about, is there a type of insurance to help meet your needs if you're unable to work and bring in your normal income? And yeah, if you become disabled, your income drops, but your expenses go up, which is often the case. Yeah, may only pay if you can't work in any job. So if they say, okay, yeah, you're not a roofer anymore, but there are jobs available and some other skill, you may have to suck it up. Can't work at any job. So anyway, what you're looking for is a policy that pays at your regular job. You fall off the roof when you're in your 50s. It's kind of a tough slog to take up bookkeeping or whatever at that point. Aim for a benefit that, when added to your other income, will equal 60 to 70% of your gross pay. Again, the taxation of your benefits will be slightly different. Do you want it to go to 65 or for life? So typically your income was going to stop at 65 when you retired, if that's when you plan on retiring. So if you're actually taking it out for your whole lifetime earning income, maybe that's a bit artificial. And that's why you could probably get by with that 65 to 75%, if it's going to go for life, because you wouldn't necessarily have to put money away for savings. The waiting period, 30 days, probably reasonable. 90 days, that's getting a little excessive. Non-cancelable and guaranteed renewable, obviously, would be important features. So the employer is most often the place. And there's an old movie of Alfred Hitchcock, Double Indemnity. There are these things where, if I die like a vicious death, murder or something like that, I get twice as much money. Mm-hmm. Accidental death and dismemberment clause type thing, as opposed to just keeling over from a heart attack. So, Social Security, which I mentioned before, Social Security itself is in big trouble. There is no notion really of a lockbox. And Social Security, too, I wouldn't say it's a Ponzi scheme, but it is paid for by the people that are working today. They're putting into the fund that's paying the workers that are now retired. Well, the problem is now that we had the baby boomers, so we had a whole lot more people working before, and now, we've talked about this labor force participation rate where we've got, 94 million people in the U.S. economy not even working. So anyway, it's tough for Social Security to keep up with that. Workman's compensation. So yeah, if you're injured, and if it's, I'm not saying to cheat or anything, but if it's traceable to your workplace, yes. If your leg gets screwed up, and it could have happened hiking or could have happened, falling off the thing at work, it probably happened at work. Disability insurance benefits limited to 70-80% of your take-home pay. So again, you're not making, more. This isn't, you didn't win the lottery here. You're just trying to make the best of a bad situation. Okay, so that kind of covers. Do you have kind of an idea of the different types of insurance? I mean, I always hate this lecture because there's just so little concrete portion to it, because it's just the way it is. It's a changing, dynamic, situation, and there's no good way to tell you a bunch of facts. And again, usually with every time I teach this course, I try to come up with some objective, comparison of the number of people insured prior to the Affordable Care Act and now under the Affordable Care Act. But you can't get it. They won't give you those numbers. You hear these numbers regarding the deductibles and the but again, they don't. It's not advertised. You have to delve into the website. You have to put in all your parameters, and then you get it. You hear the horror stories, but you don't know the rest of the story. So I can't really, in good faith, good confidence, get up here and tell you the goods and the bads. So it mainly ends up just being kind of anecdotal stuff that we kind of heard. So anyway.